questions. See, if you have a problem with it, I'll have to rearrange it next time, but I've already done certain things. See, basically the way I normally do that is, I know last time, because of time constraint, there was a bit of an issue. You guys didn't know what is going on. Basically, what I normally do is I do a question and then I discuss about that particular topic. If that is not how you guys want it, then what I have to do is I have to talk about the topic and then do the question relevant to that.
We'll go for the questions and then discuss it.
You guys understood what I'm trying to say? Yeah. Go on. Yeah.
You can go with the question, sir, based on which.
But I think there are some new students. That is what she was concerned about. And see, it's not about, see, basically, it's not about solving the question. That is not what why I'm showing the questions. So basically, the questions give an idea how things get asked. For example, if we talk about each topic in nephrology, that itself will take a very, very long time. Like if we talk about glomerulonephritis, that itself will take half an hour, 45 minutes of one session. Okay, because it's more about a refresher about what you read, clearing any doubts. But if you have a certain part of nephrology or certain areas which you're finding it difficult or something like that, you just pass on the information to the team there, and then they can communicate to me which areas you find it quite difficult. Okay, because normally what I'm trying to do is that because each area, there are a lot of, when if you look at nephrology, like if we talk about renal tubular acidosis, like, metabolic alkalosis, etc., each one will be half an hour each, which we won't have time to do all of that. You got that?
Yes, sir.
So I think there's a little bit of confusion. So what I've told the person in charge yesterday is that what I told him is I think he will probably be in touch with you. So I'm not sure how other people do. Everybody does it in a slightly different style. Obviously, everybody is very different the way they teach, etc. But what I was telling him was that if you have any particular thing which is not clear, you can tell me. I can do it a little bit more detailed in the next session or something like that with a few more slides, etc., which makes it a little bit easier for you guys to understand and see. Yeah? Got that? So now what I will do is, because of the way things, I'll just talk a little bit about the topic and do it. If you have a problem with it, just let me know. Okay? Okay. So here, now what I'm going to, my mouse is really playing up. Just 1 second. Yeah. Can you see the slides?
Yes, sir.
Okay.
Yes, sir.
The first topic I'm going to cover is about renal artery stenosis. Okay. So when it comes to renal artery stenosis, you have two things which you need to be bear in mind, particularly when it comes to with regards to exams, etc. One is what we call is a fibromuscular dysplasia that you tend to see in young women who present with resistant hypertension. And one of the causes of resistant hypertension, particularly in young women, is fibromuscular dysplasia. Okay. So here, as you can see it in the picture, there is obviously some narrowing of the renal artery happens because of the what we call is the fibromuscular dysplasia. So these patients can present with resistant hypertension, etc. Generally, what happens is in this condition, the other major differential diagnosis you have is atherosclerotic renal artery stenosis. But that tends to happen in people who are what we call as arteriopaths. So who are diabetic, smokers, elderly people, etc. You are not going to get a younger person developing features of atherosclerotic renal disease. Okay, it will be very, very unusual for someone, say, let's say 20, 30, etc., to present with atherosclerotic renal artery stenosis. Yeah, got it? Okay. Now, so if you have a younger person who's got a history suggestive of renal artery stenosis and has got a severe hypertension, the most likely is going to be fibromuscular dysplasia. Likewise, let's say you have a 60, 70-year-old or a 50, 60-year-old who's a diabetic smoker. I mean, they have risk factor for arterial disease, hypertension, resistant hypertension, particularly features of peripheral vascular disease like renal bruit, femoral bruit, and worsening kidney function, etc. That would indicate that it is more likely to be due to atherosclerotic renal artery stenosis. Okay. Now, the other thing to bear in mind is that generally, the renal function is generally preserved in the setting of fibromuscular dysplasia and hypertension. Whereas in case of atherosclerotic renal artery stenosis, generally there will be renal impairment will be there. Often it will be long-standing renal impairment. It may not be apparent at that time. The other thing to bear in mind is that one of the clinical scenario where you may pick up atherosclerotic renal artery stenosis will be when somebody has been given something like an ACE inhibitor or ARB. Because usually what happens is that when you have renal artery, when you have a compromise to the renal blood flow, the kidney tries to maintain the blood flow by activating angiotensin 2. So you can imagine that if you give somebody an angiotensin 2 inhibitor like ACE inhibitor or angiotensin 2 receptor blocker, that can compromise the kidney flow even more. Okay, so often what the other scenario where you might see in the exam setup is where somebody's got a relatively stable renal function, difficult to control blood pressure, and given an ACE inhibitor or ARB, and the renal function gets worse. See, what you have to remember that is when you give somebody an ACE inhibitor or angiotensin 2 receptor blocker, what often happens is that there will be some reduction in kidney function. That is because of hemodynamic effect. So you can get a reduction in kidney function up to 10 to 15%. That is in terms of the increase in the creatinine or reduction in GFR. Okay. However, if there's reduction in GFR far more than that, that may indicate that that patient could have renal vascular disease or renal artery stenosis. The other thing again, with regards to the exam setup, the one other scenario you need to remember that is rarely a patient with renal artery stenosis can present with flash pulmonary edema. See, basically what happens is that these patients will suddenly come in with breathlessness. The blood pressure will be very high. They will have features of fluid overload. They often have acute kidney injury. However, they are unlikely to have any issue with the cardiac function. So often the cardiac function is either preserved. There is no usual evidence of an acute coronary syndrome or anything like that. But they would have come with pulmonary edema. It could have been triggered by being treatment with ACE inhibitor or angiotensin 2 receptor blocker. Then again, you have to think whether it could be due to atherosclerotic renal stenosis, particularly bilateral renal artery stenosis causing flash pulmonary edema. Does that make sense? Do you understand that?
Okay, sir.
Any questions on
Yes,
this?
sir.
Yeah.
Yes.
Yeah. The only other thing to bear in mind is that if somebody's got a young hypertensive who you're thinking of fibromuscular dysplasia, often the intervention is beneficial. So you may have to go for an angioplasty, a stenting, etc. It will be likely to be beneficial. However, in atherosclerotic renal artery stenosis, except for very selected cases, usually intervention is not beneficial. The selected cases are most likely to be somebody with a single kidney with worsening kidney function. Second will be somebody presenting with bilateral renal artery stenosis and having flash pulmonary edema. Except for those 2 or 3 instances, usually intervention in atherosclerotic renal artery stenosis is unlikely to be beneficial. Yeah?
Yes.
Okay, you got that?
Yes.
Yes, sir.
So that is
Yes, sir.
just 1 second. The Zoom is playing up again. 1 sec. Yeah. Okay. Okay. Now, this is really repeating what I've already discussed, really. So if somebody's got a what we call as a renovascular hypertension, this is what normally happens. So there is activation of renin-angiotensin system. They often will present with features of hypertension being there for a long time, like they may have evidence of left ventricular hypertrophy, some evidence of proteinuria, etc. So generally, as I said to you already, that the one of the 2 instances where you have to bear in mind, particularly in the exam scenario, is somebody has been given an ACE inhibitor or angiotensin 2 receptor blocker, and the kidney function has got worse. And second, a patient presenting with pulmonary edema. A lot of other situations where you may come across it, but generally, it's more unlikely that your treatment is going to benefit or vary a great deal. The only other point I forgotten to mention is that one of the clues where you might see in imaging might be asymmetric kidneys. Okay, so particularly in the setting of renal artery stenosis causing hypertension, renal impairment, etc., what you might see that there might be discrepancy in the kidney size. So, for example, one person can have one kidney measuring about 6 or 7 centimeters and another kidney measuring 9 or 10 centimeters. And usually in nephrology, we regard a difference of more than 2.5 centimeter between the 2 kidneys as clinically significant. Okay, anything less than that is generally not significant, but somebody's got a difference, a discrepancy in kidney size of 2.5 centimeters or more, it would be more suggestive of renal artery stenosis or atherosclerotic renovascular disease. Okay, does that make sense? Yeah.
The one doubt, sir.
Yeah.
For fibromuscular dysplasia, it happens as bilateral disease.
Not necessarily. Can be bilateral or unilateral. Yeah.
So what will be the imaging findings in fibromuscular dysplasia?
You see, I mean, you will see renal artery stenosis only, but they are less likely to have features of other evidence of atherosclerosis. They are not going to have features of atherosclerosis elsewhere or anything like that. As I said, the best way to differentiate will be the age group. See, people are not going to present with fibromuscular dysplasia in their 50s and 60s, etc. Okay. So usually it'll be young hypertensive. Generally, it's a female between the age of 20 and 30 who will present with resistant or severe hypertension.
And we have to do renal angiogram for that.
Correct. Yeah, that's right. I mean, you can do either what is that digital subtraction angiogram of the kidneys, or you can go for particularly if you're worried about, so particularly in this, let's say a patient who has a moderate to severe renal impairment, you are worried about giving an angiogram, obviously the contrast making kidney function worse, then you can go for a MR angiogram as well. Okay. However, again, because you raised the point, I'm just mentioning it again. If there is a question later in the next class, something I'll cover that. It's that, see, contrast, that can give you a contrast nephropathy. MRI contrast is usually not a problem in vast majority of patients with mild to moderate kidney disease. However, in severe kidney disease, even MRI contrast, gadolinium contrast can give you, any guys heard of a particular condition which is due to MRI contrast? Gadolinium-based contrast. Okay, there is a condition called nephrogenic systemic fibrosis, which typically happens because of gadolinium-related contrast accumulation in patients with severe renal impairment undergoing MRI scans. Okay, so you can do an MRI without a contrast as well, just like you do a CT without a contrast. So
Can
that
you
will
repeat the name of the situation, sir?
it's
Can you repeat the name, sir?
systemic fibrosis. I can write it down if you want, just 1 second.
No, sir, I got it, sir. Nephrogenic
Okay.
systemic fibrosis.
Yeah, that's right.
Thank
So
you, sir.
this is, you only see that in patients with generally with severe renal impairment who undergoes MRI contrast media. Having said that, with the newer MRI contrast media, the risk of nephrogenic systemic fibrosis is a lot less. I've not seen someone develop, probably also because we are more cautious, but it is very rare to see that nowadays. In the olden days, when people are not aware of it, we used to do MRIs more frequently in patients with moderate to severe renal impairment. We used to see that a lot more. Nowadays, we don't see that. That is mainly due to accumulation of gadolinium-based, contrast media. Okay.
The MR angio is a diagnostic, sir.
It is. I mean, ideally, you want to do a CT angiogram, but MR angiogram provided the right person who knows how to interpret these things. It is diagnostic. It gives diagnostic information. However, if you definitely want a diagnosis, the best thing is to go for a standard angiogram, peripheral angiogram.
No, I'm a cardiologist, sir. We
Yeah.
do regular MR angio.
Yeah.
And corkscrew renal arteries are more common with fibromuscular dysplasia.
Okay. Yeah. Okay. Yeah. See, obviously, again, with cardiac, when MRI doesn't give all the information you want.
Yes,
No,
sir. Yes, sir. Yes, sir.
Heart. So just like any test, there are always a bit of limitations. If you want a definitive diagnosis, it's better to go for a CT angiogram. But the point is, let's say you're suspecting renal artery stenosis or renal vascular disease. As I've already mentioned, in majority of the people with renal vascular hypertension, the intervention is not beneficial. There are a lot of studies have been done, and all the studies have shown that very few patients benefit from intervention in renal artery stenosis. So often it's more of a diagnostic thing rather than going to be an intervention thing. So here, the MRI is likely to be helpful. You got that?
Yes, sir.
Yeah. Okay. Now, what I will do is, now I'll go back to the question. I know you got that. It's covering whatever I've already discussed really. So here you got somebody, a young woman who's presents with a severe headache. Her blood pressure is very high and it remained high. And she's went to the, outpatient clinic. She's got a bruit in the left side. The kidney function is relatively normal and she's got asymmetric kidneys. Okay, so this is like typically what we discussed just a few minutes back. Yeah. So given the age group, it's unlikely to be atherosclerotic renal artery stenosis. So here, what's the likely diagnosis? Already, some of you mentioned that already.
Fibromuscular stenosis due to fibromuscular dysplasia.
Yeah. So as I said, it's not only about getting the right diagnosis. It's also important to know why it's not the case and why the other diagnosis is not the case. Yeah. Because as I always tell people, the exam, you're not going to get the same question. There will be variations of these sort of similar questions. So it's important to know how you interpret the information given and how you come up to the most likely diagnosis. Often you have to look at other things. So here, pheochromocytoma, they're not really given any features of pheochromocytoma here. Like adrenal crisis, you will get this sweating, palpitations. See, somebody gives information like that. Pheochromocytoma has to be on the top of the list. Atherosclerotic renal vasculitis, we already mentioned. It's likely to be a slightly older person. Often they have features of atherosclerosis elsewhere. They have high risk factors like, smoking, diabetes, peripheral vascular disease, etc. Cons, how will we differentiate?
Hyperkalemia.
Hyperkalemia.
No, it's not hyperkalemia, it's hypokalemia.
Hypokalemia, yes.
Yeah, so you get hypokalemia and what's the other one you will get?
Hypokalemia with hypernatremia with
Metabolic
metabolic
alkalosis.
alkalosis.
That's right. But you have to remember that renal artery stenosis can also give you the same thing because it can give you secondary hyperaldosteronism.
Yes.
Because cons is primary hyperaldosteronism.
Yes.
Yeah. Whereas
Renal-
secondary hyperaldosteronism due to renal
Renin.
artery stenosis can also give you a metabolic alkalosis, hypokalemia. That's why the history is important. Cons is not going to give you an asymmetric kidneys. Yeah.
Yes, sir.
Yeah, so that is how you differentiate. Because again, that's what I'm saying. One of the other causes of metabolic alkalosis with hypokalemia would be Cons syndrome. They've not given the electrolyte disturbances, but renal
Also, the presence of the bruit, which is
yeah,
there.
that's right. True. Yeah, that's right. Bruit also, you are not going to get that. Yeah. Okay. And then Cushing's.
Clinical features.
Symptoms.
Features of
Similar
Cushing.
things, sir.
Yeah. So they would have given
history
other features of
of
Cushing's. Yeah. So they're not
obese
mentioning anything
individuals,
about
right?
obesity, excess hair growth, all those sort. There's nothing has been mentioned. So based on the information we have here,
Hypernatremia.
sorry.
Hypernatremia. In Cushing,
That is not-
hypernatremia also.
Yeah, hypertension will be there. Not necessarily. Again, Cushing's can also have a mild hypokalemia as well. Yeah.
Yeah,
Both
but
hyperkalemia and
hypernatremia.
metabolic alkalosis can
Yeah,
So they have-
hypernatremia will be very unusual actually. Yeah.
So I think hypokalemia and metabolic alkalosis is more both in Cushing's and Cons.
Yeah, Cushing's also can get that, but generally Cushing's patient don't necessarily develop quite severe alkalosis or anything like that. But borderline hypokalemia is often seen in Cushing's. Yeah, just like Addison's will give you hyperkalemia and metabolic acidosis, but Addison's only will rarely give you a severe metabolic acidosis. Yeah. Yeah,
Okay.
got that? Yeah. Okay. So I'm going to skip the next question. Okay. Now, the other question I'm going to talk about in nephrology is probably very common in clinical practice. I've just taken some things from one of the review articles. So basically what you have is you have a situation where you got a patient who's got both renal disease and lung disease. Okay. So that is what we mean by pulmonary renal syndrome. Yeah. And
Yes, sir.
typically in this pulmonary renal syndrome, what happens is that these patients will have evidence of pulmonary involvement, often pulmonary hemorrhage. Yeah. So alveolar hemorrhage. Okay. So often these patients will present with hypoxia, hypoxia, hemoptysis, and by lung infiltrates, which may or may not be present. Not everybody will have a lung infiltrates on the chest X-ray, but they may have a features of hypoxia as well as hemoptysis. And if you got a patient who's got a kidney injury, particularly acute kidney injury, so that what I mean by that is the patient have renal impairment, recent onset renal failure. Sometimes we may not know, and the urine will be active. Do you know what I mean by active urine? Yeah.
Sediment, sir.
Hematuria.
Yeah, that's right. Proteinuria,
Hematuria.
hematuria. Proteinuria and hematuria. Yeah. So if you got a glomerulonephritis, you are going to have usually going to have both proteinuria and hematuria. Yeah. That's what we mean by active urine. So urine is bland, usually mean very unlikely that they got a significant glomerular. Somebody's got you check the urine, there's no protein, no hardly 1 or 2 RBCs. It's unlikely that they got a glomerulonephritis. Yeah. So usually when they have a glomerulonephritis as evidenced by proteinuria, hematuria, hypertension, renal impairment, with presence of lung features like hemoptysis, breathlessness, shortness of breath, etc., you call that as pulmonary renal syndrome. Okay. Got that? And this is like almost
Yes,
like a medical emergency, actually. So because some of these patients can land in serious trouble if we don't treat them promptly. Okay. So when you have something like a pulmonary renal syndrome, there are about 4 or 5 classes of conditions which will give you this sort of finding. What you call is an acute kidney injury with pulmonary hemorrhage. That's what we are talking about, pulmonary renal syndrome. There are some other conditions where you may get some lung involvement, but they don't usually cause pulmonary hemorrhage. Okay. So when you have pulmonary hemorrhage and renal involvement, the two top differential, there are various causes I've listed here, but the two major differential diagnoses is one is ANCA associated vasculitis and second one is anti-GBM disease. Okay. Yeah. You got that?
Yes,
Yes,
sir.
sir.
Yeah. So there are also some of the other
sir.
causes like SLE, etc. But the two major causes should come to your mind. If so you got a patient or a scenario with pulmonary renal syndrome will be ANCA positive vasculitis and anti-GBM disease. Rarely somebody can have both ANCA and anti-GBM, but at least for MRCP setup, it's very unlikely somebody is going to ask you a question on that. So you got ANCA positive vasculitis or anti-GBM disease. And the way you, sometimes it can be very tricky to differentiate. So you may have to wait for your serology, you better wait for kidney biopsy and other information to come through. But one of the ways two ways you can, at least two simple ways one can distinguish is generally anti-GBM disease will come very, very acutely. So usually it will happen over a matter of few days to a week or two, generally in anti-GBM disease. The patients will come and they will get very sick within a matter of days. ANCA positive vasculitis tends to have a lot more systemic symptoms like features of cutaneous vasculitis, features of arthralgia. Often they will have upper airway involvement as well. Yeah. Particularly with the old-fashioned vagus granulomatosis, or we call it as granulomatosis with polyangiitis. Yeah, so they may have an upper airway involvement, etc. However, the true diagnosis is only going to be identified by doing a kidney biopsy. Again, your blood test like ANCA can give you an information, but rarely patients can be ANCA negative as well. Okay, so that's why it's important to go for kidney biopsy in these patients in practical situations. However, with regards to other causes, there are 2 to 3 things you need to bear in mind. And the one important cause is the eosinophilic granulomatosis polyangiitis, and other one is SLE. However, these SLE that eosinophilic granulomatosis, IgA, cryoglobulin, etc. These things are generally very, very rare in terms of causing pulmonary hemorrhage. SLE is very common in exams. SLE will cause you other lung involvement as well, but SLE presenting with pulmonary hemorrhage is generally very rare. Okay, so the most two things, as I remember that you have to think of ANCA positive vasculitis or ANCA negative vasculitis can be there, or anti-GBM disease. And generally, the diagnosis is going to be achieved by doing a kidney biopsy as well as checking ANCA as well as anti-GBM levels. Okay.
Sir,
So,
excuse me.
yeah.
Sir, and in anti-GBM disease, what will be the pulmonary symptoms?
So generally, they will just come in with pulmonary hemorrhage, features of pulmonary hemorrhage. It'll be shortness of breath, hypoxia, and hemoptysis.
Okay, fine.
Yeah, the
Thank
CT
you.
and other things might show infiltrates, etc. But clinically, it's very difficult to distinguish ANCA from anti-GBM disease or any other cause of pulmonary hemorrhage because they're all going to come with more or less a similar thing. So the features of other systemic disease elsewhere,
Network is closed.
antibodies, etc., is what going to give you the diagnosis or the clue. With regards to said, often the most useful diagnostic test is actually kidney biopsy. After treating the acute illness, that is what most of the nephrologists will do. So you can decide about the prognosis because anti-GBM, I mean, just information really, anti-GBM disease, if somebody presents with the severe renal failure requiring dialysis, usually most of them do not recover renal function at all. Whereas ANCA, the prognosis is slightly better. Even if somebody presents with requiring stage for dialysis, they can recover renal function. But anti-GBM disease, unfortunately, that rarely happens. But that is why it's important to do the biopsy. Okay.
Okay,
So,
sir. Thank you.
so with regards to ANCA associated vasculitis, you know that the old-fashioned P and C ANCA, nowadays we prefer to do more specific testing, which is PR3 and MPO, as it usually will be positive in about 2/3 of the patients. Now, anti-GBM antibodies are a lot more specific and a lot more sensitive. So usually if you have an anti-GBM antibody positive in the correct clinical scenario, it's very unlikely it's going to be like a false positive or something like that. Rarely you can have a false positive ANCA, but anti-GBM, I haven't come across it or not come across in literature either, then you're going to have a false positive anti-GBM. So it does not, at least doesn't exist in clinical practice. Okay. And there are other causes, various other antibodies that you can check. So like you do an autoimmune profile. So for example, if somebody got an SLE, you will check ANA, double-stranded DNA, antiphospholipid syndrome, you will check anticardiolipin and the lupus antibodies and the other causes, as Jovan, Rowan, etc. But for most practical purposes, these things will only rarely, very rarely give you a pulmonary hemorrhage. So the top two differential, again, I'm repeating the same thing really, is ANCA positive vasculitis and anti-GBM disease. Okay.
Okay, sir. Thank you.
Sorry, just 1 minute. Okay. Again, you don't have to worry too much about the treatment part, but basically, with regards to most of these conditions, the two things you have to bear in mind. Okay. One is what we call as an induction therapy. So induction therapy is what the initial treatment is. And then we have what we call as a maintenance therapy. And very rarely you'll be asked about maintenance in MRCP exam, as far as I know. But sometimes they may ask, what is the right treatment for this situation? So let's say you got a patient with pulmonary hemorrhage and he's got an acute kidney injury. So what is the standard treatment? The standard treatment is, particularly if somebody's got a pulmonary hemorrhage, most nephrologists will opt for plasma exchange. Okay, to remove the circulating antibodies, and that's definitely it has to be done in the setting of anti-GBM disease. In good pastures microscopic polyangiitis, granulomatous polyangiitis and microscopic polyangiitis, that is ANCA-associated vasculitis, there is no hard evidence that plasma exchange is beneficial, even though most nephrologists will do plasma exchange in the setting of pulmonary hemorrhage, because that is like a life-threatening condition. Actually, most of these patients, if they're going to lose their life, it's going to be because of pulmonary hemorrhage, not because of acute kidney injury. So if they have a pulmonary hemorrhage, it's a very bad prognostic marker. So usually you have to treat them with plasma exchange. But however, what you have to remember is the plasma exchange, what is going to do is just to remove the circulating antibodies. So you have to stop the production of antibodies by giving the other induction treatment. And the standard treatment is two things. One is intravenous followed by oral steroids, and other one is usually cyclophosphamide, but we also can consider rituximab in patients where you're worried about the toxicity of cyclophosphamide. Yeah. And what's the toxicity of cyclophosphamide you need to bear in mind, particularly in young people?
Infertility.
Exactly. Both in men and women, though people generally talk about female infertility, it also causes male infertility as well. So if you have a patient, you are worried about infertility, you can opt for rituximab instead of cyclophosphamide. Okay. So the standard treatment is, most of these conditions, the treatment is more or less very similar. So you give an induction treatment, either pulse methylprednisolone followed by oral steroids, intravenous or oral cyclophosphamide. That depends on the, I personally prefer IV cyclophosphamide. Some nephrologists prefer oral cyclophosphamide. You can consider rituximab in the setting where there is a concern about fertility, or somebody's got a severe sepsis or something like that. There's a rituximab. So that's what you do. As a plasma exchange, definitely indicated in the setting of anti-GBM disease. In the other situations, if there is evidence of pulmonary hemorrhage, you would opt for plasma exchange in most situations. And then you go for the maintenance treatment, which is going to be usually combination of steroids plus MMF or azathioprine. That is what you call as MMF is mycophenolate, particularly in SLE, etc. Whereas generally most nephrologists would prefer azathioprine, which has got a better data in the setting of ANCA-positive vasculitis and anti-GBM disease. Okay, just a quick brief summary of it. But if you got any questions, you can stop me. I can go through it.
Sir, excuse me.
Sorry.
Sir, what's all abbreviation? This is AAV, non-NAV, GPA.
I told. That's what we went through in the previous slide. Sorry, you got that here, no? This is what is short. Yeah, so this is ANCA-associated vasculitis, non-ANCA-associated vasculitis. Yeah, these are the two things. Yeah. So then they put granulomatous polyangiitis and microscopic polyangiitis. Then eosinophilic granulomatous polyangiitis. Then you have double positive, I mentioned briefly, that is, these patients are both ANCA and anti-GBM positive. Then you have non-ANCA-associated vasculitis, you have anti-GBM disease, antiphospholipid syndrome, and SLE, systemic lupus erythematosus.
Okay, thanks.
And the CYC refers to cyclophosphamide. Plexus plasma exchange. Okay, IVIG is IV immunoglobulins, which we rarely give. And here on the right hand side, oops, sorry, just one second. The drugs mentioned are AZA stands for azathioprine, MTX stands for methotrexate, CYC cyclophosphamide, and then rituximab.
Okay, sir. Thanks.
Okay. Any questions on that? Because I'm going
Thank
to
you,
a question in a minute on that. Any doubts on this
Thank you.
one?
Thank you, sir.
No questions. Okay, fine. Yeah.
It's a nice review article, sir.
Yeah. That's it. You can, if you want, you can take a note of that. Just if you want, you can note it down. I'll keep it for a few seconds.
Journal, sir. Which journal, sir?
Yeah, that's what I showed. Oh, sorry, I didn't realize that the journal name didn't come up. Oh, it's I'll ask them to send it to you in the group. Okay.
Okay.
I thought I put the journal title like this is the review from pulmonary
Okay.
clinical review. Yeah, it is some respiratory journal or something like that from my memory. But I'll send it or at the end if I find it, I have it in my system. I think I'll put it in the end. Okay.
Okay, sir. Okay.
Okay. Just I should remember just in case if I don't remember, just remind me. Okay. Now, sorry, there's a problem of going through the questions again. Okay. Okay. So you have a young person who comes to the emergency department. Just 1 second. So young person who presents to the emergency department with a 3-day history of shortness of breath. He's been unwell for about 2 weeks with a flu-like illness. He's a smoker of 20 cigarettes per day and a social drinker. There is no family history of note. His pulse is okay. He's a bit hypertensive. Oxygen saturation is 96% on 6 liters of oxygen. And he's got active urine as evidenced by proteinuria and hematuria. And chest X-ray shows bilateral pulmonary infiltrates. And these are the investigations. He's got a acute kidney, he's got renal impairment with a creatinine of 540 micromoles per liter. He's got he's got hyperkalemia. And the question is, what is the most likely diagnosis? So you have post-streptococcal glomerulonephritis, systemic lupus erythematosus, microscopic polyangiitis, Goodpasture syndrome, and IgA nephropathy.
Sir, please show the question again.
Likely to be Goodpasture, sir.
Yeah, just go through it again. I'll let the others give a chance. Yeah, go through it again.
Post-streptococcal.
No, please wait. No, please wait. Okay, you got that?
Yes, sir.
Okay. So here, 1 second, sorry. So as I told you already, he's got a pulmonary renal syndrome. Okay. Now, post-streptococcal doesn't usually give you pulmonary. They've not given that he's got hemoptysis, but he's got bilateral pulmonary infiltrates. Post-streptococcal doesn't usually do that. The only explanation you could have would be features of fluid overload, which may look on the X-ray as pulmonary infiltrates. But typically, these patients will have like evidence of upper respiratory tract infections. But they have not given any information about that. Yeah.
The only thing is that, sir, that past 2 weeks with flu-like illness
That's
could be a little
That's true.
confusing.
Yeah. But it could be any infection. No. See, a lot of these vasculitis
Yes.
is often triggered by some sort of a viral illness or something like that. So if you take a history in these patients' vasculitis, you will find that often there will be a prodromal illness where they will have fever, flu-like illness, joint pain, etc. But the point is about based on the information we have here. Okay. So don't try to think that the question is always trying to, they're trying to hide something or something like that. Generally, they don't do that in my experience. Okay.
Sir, while reviewing it, I just read that in post-streptococcal glomerulonephritis, there is more of proteinuria than hematuria. But in IgA, there is more of a hematuria than proteinuria. Is it so?
Again, these things are not necessarily very helpful, but generally what happens is that patients post-streptococcal GN often have marked fluid overload, generally. Because you see generally in the kids, your point is like they often have, see, the problem with this is that urine routine does not give you actually the exact quantity of proteinuria. You need to know either do a 24 urine protein collection or do a protein creatinine ratio. Okay.
Yes.
No, I got your point. That's reasonably correct, but it is not always true.
Okay.
People with vasculitis can also have a lot of proteinuria as well. Okay. The point is that you see, one is that there is a relatively short duration. It can happen with post-streptococcal glomerulonephritis as well. But they given that there is not really mentioned about any features of volume overload or anything like that. And typically, patients with post-streptococcal GN tend to have a lot of volume overload. Generally, they will come with a lot of edema, etc. And as I said, they've not given any information. Often there will be information that they've developed a sore throat or an upper respiratory infection or something like that. Okay. Yeah. Now, with regards to, they have not specifically mentioned that whether it could be a microscopic polyangiitis or Goodpasture syndrome or something like that. It's usually, as I've already mentioned, microscopic polyangiitis often the evidence of upper airway involvement. They may have a history of recurrent history of sinusitis, having ear block. So those sort of things tend to suggest it's more likely to be microscopic polyangiitis rather than Goodpasture syndrome. The other thing is, which I'm going to go through in a minute, is that smokers are more vulnerable to pulmonary hemorrhage, particularly in the setting of anti-GBM disease. Okay, so that's also a hint why they given this sort of scenario. Okay. Yeah. So as I said, he's got a pulmonary renal syndrome, but based on the information we have, this is likely to be a Goodpasture disease rather than, that's anti-GBM disease rather than ANCA-associated vasculitis. But as I said, clinically, sometimes it can be very, very difficult to rule out. And as I said, some rarely people can have both. But for the exam perspective, they've not given any information about upper respiratory tract involvement or anything like that. They've not also given much information about other skin or joint involvement, which makes it ANCA-positive vasculitis less likely, but you cannot rule it out. Okay. But as I already mentioned, there is increased pulmonary hemorrhage, particularly in Goodpastures in case of smokers. Okay. SLE, they're not given any other information that this patient has got any features to suggest that he or she is going to have SLE. Although male, it just makes it less likely he's going to have SLE. It doesn't mean, again, not rule it out, but there is no previous history of SLE. It's very unusual for patients with SLE for the first time to come with pulmonary renal syndrome. It will be very, very unusual. Usually they would have evidence of other organ involvement, skin involvement, joint involvement, etc. Going on for a period of time, they may missed medicines or they've been given repeated course of different drugs and they've not responded, etc. Okay. And the PSG and IJ already mentioned that I said they've not given history of streptococcal infection. They not mentioned a lot of edema, etc. So as I said, it all makes it more likely that this is going to be Goodpasture syndrome. Okay. Got it? Yeah. Any questions on that?
No, sir.
Okay. Okay. My next question is going to be on acute kidney injury. Okay. So when you have acute kidney injury, you know that the classical teaching is you have to think of three things. One, it could be a pre-renal acute kidney injury, or it could be an intrinsic kidney disease, where it can be glomerular or tubular interstitial. And third, it can be a post-renal or what we call as an obstructive uropathy. Yeah? Got that? Okay. Yeah. So when it comes to a pre-renal acute kidney injury, usually it is due to either absolute or relative reduction in the blood volume. Okay. So absolute can be, it's typically what we see in clinical practice. If somebody got a history of vomiting, eaten some nasty food outside and developed severe vomiting or developed severe loose stools, or it could be in the ICU setup where we will see where the patients had a road traffic accident, lost a lot of blood, or it can be post-operative blood, intraoperative blood loss, or it can be sepsis with severe vasodilatation, etc. So that can be an absolute, vasodilatation not necessarily absolute, but absolute reduction in blood volume. So what happens is there is reduced renal blood flow. The kidney will try to compensate to an extent, but beyond a point it may not, and the patient can develop acute kidney injury. That is what we call it as pre-renal acute kidney injury. The second thing is it will happen in the setting of like post, for example, in a patient, the cardiologist like a heart failure, where there is, let's say they got an acute heart failure, there will be reduction in effective circulatory volume. Again, the kidney perfusion can be compromised. Okay, so they also can develop a pre-renal acute kidney injury. Okay. Yeah.
Okay, sir.
Yeah. Now, with regards to pre-renal, there are two things. One, sometimes what happens is the patient will be what we call is a volume responsive phase. So initially, when a patient comes in with acute kidney injury, what happens is in the setting of hypolemia, the kidney will try to compensate. They will maintain the urine output, etc. However, if this persists for a long period of time, they can go on to develop acute tubular necrosis. Okay, and some of these patients, as and when things are corrected over time, they may recover renal function. But once ATN set in, the kidney may not recover very quickly. It may take time for the kidney to recover. And generally, if you check the urine in these patients, it will be bland. So basically, they're very, because they don't have any pre-existing kidney disease, or for most practical purposes. I mean, it couldn't be a guy with a diabetic nephropathy who comes with a pre-renal AKI. But for most practical purposes, these patients are going to have a normal urine routine or a bland urine. So they are not going to have a proteinuria or hematuria or etc. Okay. Yeah.
Okay,
So
Yes,
here
sir.
you can correct the volume. Usually the renal function will recover in some patients. Some patients may go on to have acute tubular necrosis. You dialyze them for a period of time, or you treat them for a period of time, and some of them may recover renal function back to normal levels. So generally, you don't need to give any specific renal therapy in the setting of pre-renal acute kidney injury, apart from doing dialysis, etc., because there is no glomerular pathology or anything like that. Okay. Now, the second thing what we have is an intrinsic kidney disease. So where it can be two things commonly. One, it could be a glomerular pathology, like we discussed the other patient, like the most common things being primary glomerular disease. Like it could be a what's that vasculitis, it could be SLE, it could be IgA nephropathy. There are various kidney conditions, etc. are there. So it could either be due to a glomerulonephritis, or it can be what you call as a tubular interstitial disease. And the glomerulonephritis, generally the patients are likely to have some markers of inflammation in the kidney. So often they will have obviously all of them will have a high creatinine. Generally they are hypertensive. They will have often a features of fluid overload, and the urine is usually active. So often they will have proteinuria, hematuria, etc. Okay, so that's why I always tell people, if somebody got acute kidney or acute kidney injury, the most useful test actually is urine routine. The urine routine will tell you whether the patient is going to have likely to have a pre-renal or intrinsic kidney disease or not. So you can tailor your treatment accordingly and tailor your evaluation accordingly as well. Okay. The other part is what we call as a tubular interstitial disease, which is usually due to drugs that we give to our patients. And so where basically the glomeruli are fine.
So one doubt, sir.
Yeah.
So if a patient is having long-standing diabetes and presents with acute kidney injury, and if his urine routine showing proteinuria, so how can we differentiate in that case?
The only way you can differentiate is that by going through the history, really.
Okay.
History, and second one is hemodynamic findings. Yeah. So as I already mentioned, that diabetic nephropathy is not going to give you an acute kidney injury. Yeah. So if you got, often the most useful in this situation will be the previous record of renal function, etc., if it's available. So let's say you got the previous reports available and the creatinine was talking about in Indian settings. So let's say 80 or 90 micromoles per liter, and now he's got a creatinine of 300 micromoles per liter. Diabetic nephropathy is not going to progress over a period of 2 to 3 months to that sort of a level. Yeah. You got that? No.
Yes, sir.
Yeah. Again, the other thing will give you a clue is generally in diabetic nephropathy, you are not going to have hematuria or something like that. So if they got a hematuria, see, it's a real problem we face in clinical practice, because in India, diabetes is so common. A lot of our patients come with other kidney disease, often have diabetes as well. So sometimes it can be very tricky to differentiate whether they got a diabetic nephropathy or some other kidney disease or something like that. So that's why the history is very, very important. If they have a record of previous renal function, that will also be useful. So the history you take is, if they've been unwell, they can take an outside food, they had vomiting multiple episodes, or they had a fever, they've been treated for a urinary tract infection, etc. So that's what will give you the hint. So you have to go by the history only in those situations. Urine routines may not be very accurate in that setup. Yeah.
Sir, excuse me.
Sorry.
Sir, excuse me, sir, from Dr.
Yeah.
Vijay.
Tell me. Yeah.
Sir, regarding renal context of acute renal injury.
Yeah. Sir, I couldn't hear. What did you say? Renal findings? Sorry, what did you say? Can you please repeat it? Can you repeat? I couldn't hear you what you said. Sorry, guys, can you hear me?
Yes, sir, we are able.
Someone was asking me a question. I just asked him to repeat it because I couldn't understand it first time. No? Okay, fine. So you got that? No. So either pre-renal is generally due to absolute or relative reduction in blood volume. Absolute, we discussed, usually the common things we face in clinical practice. Relative, typically in heart failure, or it could be in sepsis where there is a intense vasodilatation. So there will be reduction in blood flow to the kidney. So intrinsic renal we talked about. So as at the glomerulonephritis, you identify by presence of proteinuria, hematuria, hypertension, edema, etc. Tubular intestinal nephritis, again, where the history is usually very, very important. Okay. And the common causes of tubular intestinal nephritis in clinical practice are antibiotics, PPI, NSAIDs, etc. These are three classes of drugs you typically see in clinical practice. So antibiotics, in theoretically, almost any antibiotic can give you a tubular intestinal nephritis in theory, commonly penicillins, but as at almost any antibiotic can do that. Second is non-steroidal anti-inflammatory drugs, including COX-2 inhibitors. So they can also give you a tubular intestinal nephritis. And third one will be, what did I miss? PPI, proton pump inhibitors. They're also notorious for causing both acute and chronic tubular intestinal nephritis. Okay. Yeah. So the acute tubular necrosis is like a pre-renal insult only, which when it persisted for a longer time, the patient will go on to develop acute tubular necrosis. That's what usually happens. So hypovolemia been there for a long time, sepsis been there a long time. So the patient will go to a shutdown. You have to support them by dialysis, and hopefully when the underlying illness gets treated, they will recover. Okay. Now, the third thing, which is usually often surgical, though can be in medicine as well, is the post-renal cause of acute kidney injury. So these are usually due to obstruction to the urinary tract, which can either be due to something in the bladder or something higher above. And one of the rare causes of something higher above will be retroperitoneal fibrosis. But that's generally is rare in clinical practice. You will see that when there is some association with malignancies, etc., lymphoma. Somebody with a lymphoma coming in with an obstructive uropathy, always have to, one of the top differential diagnoses you have to think of is retroperitoneal fibrosis. But the other common causes in clinical practice will be, prostate malignancies, urothelial malignancies, prostatic enlargement, and the other thing is renal calculi. Though renal calculi is usually unlikely to cause a bilateral obstruction. It's very, very rare. I mean, generally you'll see unilateral obstruction, and unilateral obstruction per se should not make your kidney function worse unless there is something wrong with the other kidney as well. So unless there is a bilateral renal calculi, it's very unlikely a renal stone will give you an acute kidney injury. Okay. And obviously in the kids, etc., you will see things like phimosis, causing obstructive uropathy. Okay. Any question on that?
Sir, I had a question.
Yeah.
Just I was expressing that time.
Yeah.
So can you hear me?
Yeah, I can hear you. Yeah, go on.
Sir, sometimes patients getting the antihypertensive to control her or his blood pressure.
Yeah.
But some of the antihypertensive also causing the this fall of the blood pressure on off in long-standing cases.
Yeah, yeah.
And this type of falling blood pressure can cause this renal function to deteriorate.
Definitely, it can. Yeah, yeah.
Chronic basis.
Yeah, definitely. Actually, you come to the right time. I'm going to another slide, which is one of the slides I often like in explaining hemodynamics in the kidney. Can you see this picture? This is a very, very old.
Yes, sir.
Okay, so this is what normally happens. So you can see it clearly, no? Can you guys see the picture clearly?
Yeah.
Yes, so I'll go through that. See, basically, what you have is that the normal GFR is maintained by both afferent and efferent arterioles. So basically, normally what happens is that the afferent and efferent, regulate the blood flow to the glomerulus. So let's say somebody's getting hypovolemia, like the patients we discussed, somebody's got a hypotension or hypovolemia due to whatever. It could be dehydration. It could be due to something else, like vomiting, blood loss, etc. What normally happens is usually you open up the afferent. Okay, so that is what is the blood is going into the glomerulus. So you open up the afferent by mediating through prostaglandins. Okay, and in the efferent, what happens is that kidney will activate release of angiotensin 2, and that angiotensin 2 will cause constriction of the efferent arteriole. Yeah, you got that? So you're opening up what's going in and closing up what's coming out. So what's going to happen in the pressure?
Let's go to rice.
When you maintain, yeah, that's right. So you got so because your kidney is very vulnerable to hypolemia. So you're dropping your blood pressure. So this is what the kidney will normally try and do by opening up the afferent and closing up the afferent. And thereby you maintain the glomerular blood flow. So the kidney tries to conserve the kidney function to an extent. So unless obviously it goes on for a longer time, the kidney may not be able to do that. The patient will go and develop pre-renal acute kidney injury and later on maybe acute tubular necrosis. Now, this can be compromised by two things, which I've already mentioned. One is NSAIDs and COX-2 inhibitors. Okay. So as you know, NSAIDs work on prostaglandins. Yeah.
Yes, sir.
You remember that from physiology, whatever.
Yes,
So,
sir, yes, sir.
so yeah. So what happens is if you're taking NSAID, you cannot open up the afferent. Yeah. Isn't it? Likewise, you also take an ACE inhibitor together with it, you are in big trouble because you cannot open up the afferent, you cannot close the afferent. So you're going to have a much more rapid acute kidney injury. You got that? So why patients taking NSAIDs and ACE or ARB, the same applies to ACE, ARB, etc., whatever they are. All these class of drugs are going to work in the same way only. So you take all these two together, you are, particularly these two together, you are more vulnerable to acute kidney injury. So that is why you find that people who are taking ACE for a long time, sometimes they'll go to the doctor for some joint pain or something. They will have got an NSAID, they have acute kidney injury. And this is usually the mechanism behind that. Or it could just be an intercurrent illness, they got a vomiting, dehydration, etc. And these drugs will exacerbate or aggravate the chance of them developing a pre-renal acute kidney injury. Yeah?
So the ACE-ARBs act on the efferent vessels.
Correct, that's right.
It is on the afferent.
That's right. Yeah, yeah, that's right. Yeah. Taking both together is absolutely leads to a very high risk of acute kidney injury, particularly in the setting of hypolemia. If they're euvolemic, it will be fine. Like mentioned, though, you said they are taking hypertensives for a while, but suddenly, for some reason, they get a febrile illness, they get hypolimic, and they'll go to the doctor. Somebody will give an NSAID for a temperature without realizing their background clinical status, so they can land in serious trouble because of that. That's what often you take a history, you will find out. Understood? Any questions on this one?
No,
okay,
sir.
thank you, sir.
Okay, now I'll go to the question. Okay, so this is similar to what we discussed really already. So you got an old lady who comes to the hospital with diarrhea and vomiting for about 2 days. She's taking enalapril and amlodipine for high blood pressure, and she comes to the hospital. JVP is not visible, her blood pressure is a bit low, and urine analysis shows no protein or blood. Okay, so this is typically what it is. We just discussed it, isn't it? I mean,
pre-renal.
Yeah, that's right. So this is, in clinical practice, never going to be this straightforward, but that's what usually happens. We got the situation where somebody who's taking ACE inhibitor fine, old lady, suddenly develops a GI upset, then becomes hypotensive and unwell. So the fact that she does not have any evidence of glomerular disease by proteinuria, absence of proteinuria hematuria, this is likely to be a pre-renal acute kidney injury. Okay. So you've done the investigations. So you got hyperkalemia, sodium is normal, 132, potassium is 5.7, urea is elevated, and creatinine is also elevated. So that's a 380 micromoles per liter. So here, so what is the most likely cause of kidney injury? So here it is likely to be we just discussed it, no?
Acute tubular necrosis.
Exactly, that's right. So I told you it's a pre-renal AKI, but once it exists for a period of time, patients can develop acute tubular necrosis. Okay, it's a consequence of a pre-renal AKI. That's what acute tubular necrosis, when the kidney goes to shut down and the renal function starts to go off. So acute papillary necrosis, usually you see that in the setting of NSAIDs, and rarely you see that with, or India we see it commonly actually, with the pyelonephritis, particularly in a diabetic patient. Okay, but with regards to exam, there are three causes of acute papillary necrosis. What are they? So I already mentioned diabetes and NSAID. What's the third cause, which often comes up with the MRCP exams? Anyone?
Reflux?
No. That doesn't cause papillary necrosis. It's relatively common cause of papillary necrosis in MRCP exams. I'll give you a clue. They will give you a scenario on Afro-Caribbean man.
Oh, sarcoid.
Not sarcoid. No. Sarcoid doesn't do that. Sickle cell,
SIV?
sickle cell trait. Sickle cell trait. You forgotten that? You remember that?
HSP.
You haven't come across it, you guys?
Penicillin purple.
Yes, sir. Yes,
Sorry?
sir.
Yeah, so sickle cell trait. Okay.
Self-trait.
That's one of the rare,
Okay.
particularly if they give a scenario about an Afro-Caribbean man or somebody from Africa coming because they have a higher risk of sickle cell disease and sickle cell trait. So they give a scenario, they have acute kidney injury. Usually they'll say patient came in with pain, renal function is worse. The top differential diagnosis is going to be acute papillary necrosis. Cast nephropathy, when will you see that?
Myeloma.
Exactly.
Myeloma.
So again, there is no clue. Older people are more like the myeloma, but they're not given information to that. So what are the clues that might be in the scenario? What could they have given you to suggest that it could be cast nephropathy?
Old age and backache.
Yeah. So pain. Yeah. Bone pain or back pain. Okay. Second.
Crab symptoms. Sir.
Sorry. What did you say? Cramps.
Crab
Crab symptoms.
Oh, crab criteria.
Yes,
Okay.
criteria.
Fine. Yeah. So hypercalcemia, anemia. Yeah.
Yes, sir.
Yeah. Hypercalcemia, renal impairment, anemia, and bone issues. Yeah.
Yes,
Yeah.
sir.
So they might, I mean, with regards to the scenario, sometimes they may not give us. So sometimes they may give an issue about hypercalcemia. So particularly, you got a patient with acute kidney injury who's got a high calcium, you have to think of multiple myeloma. But you generally, in acute kidney injury, calcium should be low. So if somebody's got a high calcium, you have to think of myeloma. Other clue might be, they might give us complete blood count, and what might you find there, apart from anemia? That would indicate it could be multiple myeloma. You often
Yes, sir.
Benjo-
Yes, sir.
exactly. ESR, correct. Yeah, that's ESR will often be very high, usually more than 100. Okay. So older person, renal impairment, high ESR, always think of multiple myeloma. Okay. So now, that's are the clues. So that's how you pick up from the information what is given there. You know, you pick up, connect them, try to come up with the right diagnosis. Rhabdomyolysis.
Sir, in sepsis also you can get cast
Creatinine
nephropathy.
kinase.
Very unlikely, actually. I mean, you're probably confusing with acute tubular necrosis, I think. Sepsis per se shouldn't really cause you cast nephropathy.
Okay.
Yeah. You can, yeah. So rhabdomyolysis.
Creatinine kinase will be very much
Yeah, so they
elevated.
may give you a clue about creatinine kinase, but if they don't give you, what's the other thing they will
And
commonly put in the exam?
history of a fall or the patient is found lying down for a long period of time.
That is the correct. Yeah. Often there may be history of fall, or patients have been found on the floor, and been on the floor for a long hours. They may give a history of patient taking statin, yeah, which increases risk of rhabdomyolysis, yeah.
Yes, sir.
Yeah, statin intake might be there. Just 1 second, just a one hospital call, just 1 second. Just to 10 seconds, yeah. Hello. என்னம்மா நான் பார்த்துக்கிட்டுறேம்மா, நீங்க நான் கொஞ்சம் ஒரு மீட்டிங்ல இருக்க முடிச்சுட்டு கால் பண்றேன். ஓகே. இல்ல ஃப்ரீயா இப்போதைக்கு ஆரம்பிச்சுக்கோங்க, நான் பார்த்துட்டு சொல்றேன், அப்புறம் பேசிட்டு சொல்றேன். அது என்ன எப்படியும் சிபிஆர்லாம் பண்ணியிருக்காங்க, நான் ஃப்ரீயாவே இருக்கட்டும், நான் பார்த்துட்டு சொல்றேன். சரி. ஓகே, சரி. Sorry, some guy was a bit sick in the hospital. That's all. Yeah, you can hear me, no? So yeah, so there will be scenario about patient taking statin. What might be the clue in the urine?
Myoglobinuria.
Yeah, if they don't give that, what else they might give?
Blood.
Exactly, because the myoglobin will be some misread by some urine routine as blood in the urine. Yeah, good, very good. So that is how you pick up things. Okay, acute tubular necrosis, which covered that. Tubular intestinal nephritis, there will be history of some
Dogs.
yeah, some you may see minor like a trace protein, 1 or 2 RBCs might be there, but usually the history is very, very important. There may be a recent intake of an antibiotic for a viral illness or something like that. They're usually hemodynamically not compromised, and there there will be recent history of flu or something they've given an NSAID antibiotic, or the what's the third one, proton pump inhibitor or something like that. Okay, so this is how you will distinguish or differentiate between the different things. Okay, right. Okay, this and all I covered. Okay, actually, my next question is on the similar topic that we discussed actually. Okay, so the next thing, I'm going to have it talk about this, is actually tubular interstitial nephritis. Okay, so the tubular interstitial nephritis, or at least in theory, any drug can give you that. There are various drugs, including drugs from ATT, antibiotics, antiviral, NSAIDs, etc. But generally, the common drugs are what we already discussed. I said, theoretically, any antibiotics, usually penicillins, but in theory, any antibiotic can give you that. Proton pump inhibitors are notorious for causing tubular interstitial nephritis. And the third group will be, what is that? NSAIDs, which I've already mentioned. But there are various other causes, even anti-epileptics like phenytoin, carbamazepine can do that. ATT drugs, the common one is rifampicin, and sulfur-based drugs can also give you tubular interstitial nephritis. So generally here they would have given a history of drugs being given in the recent past. So they don't usually have features of glomerulonephritis. So the urine is unlikely to be very active, like very unlikely to have significant proteinuria, hematuria. Usually these patients are normotensive and the creatinine can be high. Okay, so here really you have to go by the history of the information given. Okay. The only other thing to bear in mind is that rarely they may give a scenario where there may be a patient with a granulomatous interstitial nephritis. You heard about that?
Pseudomonas infection and diabetic.
No, not that. No. Granulomatous interstitial.
Granulomatous.
Yeah, granulomatous. So the two things you have to think of. One is
tuberculosis.
Yeah, TB. Correct. Very good. Other one is it's always differential for TB.
Sarcoidosis.
Yeah, exactly. Yeah, so those are the two causes of granulomatous interstitial nephritis. So you look at granuloma, whether it's caseating or non-caseating. Caseating indicate most likely to be TB and non-caseating sarcoid. Yeah, so that's how you'll differentiate. Just something to bear in mind. If they're given a scenario where there is some suggestion like hypercalcemia, some lung involvement, etc., think of sarcoidosis. Okay, right. I'll go to the scenario in a minute. Okay. Sorry, the question. Just 1 second, please. Yeah. Sorry, yeah. So 40-year-old man presents to the emergency department with a widespread maculopapular rash. He was recently given a course of antibiotic for upper respiratory tract infection. On examination, he was well. Urine shows 1+ blood and a trace protein. His full blood count was normal, and 1 month back, he's got a normal serum creatinine, and right now, his serum creatinine is almost double the normal limit. Okay. So what is the most likely cause? So we discussed it already. So this is fairly obvious. Yeah. So what's the likely diagnosis?
Tubular interstitial nephritis.
Yeah, that's right. So we already discussed it, papillary necrosis. So usually you see that in people are taking NSAIDs. So they often have pain with obstructive uropathy because the papillae will come and block the ureter. So they may have a unilateral or a bilateral obstruction. Okay. Often they will have pain. If they have it due to pyelonephritis, they will have fever, loin pain, etc. If it's due to NSAID, etc., they may not have much pain. But your imaging will show obstruction with the dilated ureter, etc. IgA nephropathy, there's no really history of hematuria after respiratory tract infection or anything like that. They're not hypertensive, so the history doesn't fit in with it. Post-streptococcal glomerulonephritis, we already been through that. So I told you, usually it'll be after a respiratory tract infection. Often they will have edema, proteinuria, hematuria, hypertension. So none of which is present in the current patient. Acute tubular necrosis is possible, but there is the history of the antibiotic. There's not much evidence of patient being hypolimic or taking ACE or NSAID or an ARB, which makes it less likely. You can never rule it out, makes it less likely. So based on the information we have, it's likely to be acute tubular interstitial nephritis. Rarely, yeah, sorry, 1 second. Yeah, I thought I missed something. Rarely, these patients can have a eosinophilia or eosinophiluria, but in clinical practice, it's rare. Okay, so sometimes they may give a scenario where they may say that this patient on clinical, the CBC might show a bit of eosinophilia or something like that. But in clinical practice, it's very, very rare. So if it is there, it's useful. If it's not there, it's not going to be useful. Okay. Any question?
Sorry to interrupt you again. Could you please just state the causes again for acute papillary necrosis, sir, please?
The 3 major causes are NSAIDs. Okay. And the other one is
yes,
pyelonephritis, particularly with diabetes. And third is the sickle cell trait.
Yes, sir. Thank you, sir.
These 3 are the major causes. Yeah. Right. Okay. The drug, there are many of them, but the history is what will give you the clue. Okay. Now, the other thing is, 1 second. Yeah. Okay. Sorry, just 1 second, so that I remember what my question is. Now, the other thing is that what are the how one can reduce the progression of diabetic kidney disease. Okay. So when the hallmark of diabetic kidney disease is what? What is the hallmark of diabetic kidney disease? How does it usually present?
Glomerulosclerosis.
Yeah. So usually they will start with proteinuria, then they will go on to our albuminuria, and then they will go on to develop a progressive kidney disease as a result of diabetic kidney disease. So here often the question is, obviously you have to control the glycemia, etc. But when it comes to the treatment of diabetic kidney disease, usually the treatment is to reduce the proteinuria, thereby reduce the risk of progression of kidney disease. So we often use these drugs in the setting of diabetic kidney disease, even when the blood pressure may not merit it. So the blood pressure may not necessarily be high, but we may give these drugs to reduce the proteinuria and reduce or slow down the progression of diabetic kidney disease. Now, when it comes to that, there are 3 classes of drugs that we currently have available, or actually you can say 4 if you separate AS and ARBs. So class of drugs that you can use to reduce the proteinuria or albuminuria and slow down the progression of diabetic kidney disease. Okay. So the first, you can go for an ACE inhibitor or an angiotensin 2 receptor blocker. For practical purposes, there is very little difference between the two. Apart from, what is the major difference between ACE and ARB?
Angioedema is less when compared to
angioedema. The other one?
Chronic cough will be seen in case of
hyperkalemia risk is very similar. I mean, so theoretically, some can say ARB slightly better, but hyperkalemia risk is almost very similar between these drugs. But the 2 major things you have to bear in mind is angioedema, because sometimes cough. Yeah, that's right. Yeah. Cough as well, cough and angioedema. So, and somebody develops an angioedema with an ACE inhibitor, you can go for an ARB. Generally, in clinical practice, ARBs are better tolerated. So sometimes they may give a scenario about patient taking ACE for a while, developing chronic cough, which is not settling down. So it could be an ACE-induced cough. So you can go for an ARB. Okay. So for most practical purposes, there is very little difference between the 2. So most nephrologists nowadays prescribe ARBs and ACE, or even most of the cardiologists also tend to use ARBs more than the ACE inhibitors. So when it comes to the individual drugs, there is really very little difference between the 2. Okay. So that is number 1. So you can go for an ACE inhibitor, ARB. So what is the second line drug that you can use for diabetic nephropathy? Yeah, it's SGLT2 inhibitors. Yeah, you're familiar with them, no? It acts on the sodium glucose transport receptor. So they make you excrete more glucose as well as sodium in the urine. These drugs they don't have a major effect on the blood pressure, though they can cause a slight reduction in blood pressure. Generally, they don't cause. So if you got a patient who's got a diabetic kidney disease, who's not much hypertensive, and you want to give a drug to reduce proteinuria, these SGLT2 inhibitors are often beneficial. There are various drugs, empagliflozin, dapagliflozin, etc. Again, there is very little difference between these drugs. They're also effective for a patient with left ventricular dysfunction. There's a lot of data which shows that reduce the progression of both kidney disease and improve cardiovascular outcome in both diabetic and non-diabetic kidney disease as well. So if you control the blood pressure with ACE or ARB, then you can go for SGLT2 inhibitors like empagliflozin, dapagliflozin, canagliflozin, etc. for them. Okay. What are the side effects of these drugs?
UTI.
Yeah, that's a major side effect of these drugs, really. The increased risk of, actually, in clinical practice, I see a lot of pyelonephritis in patients taking these drugs, because in India, already the urinary tract infection is a major burden, really, in clinical practice. So if somebody's got a recurrent UTI, somebody's got a risk of recurrent UTI, it's better not to use these drugs, or use them very cautiously. Tell the patients to come to you or report regular voiding, adequate water intake, etc. So again, these drugs are very similar to ACE in the sense that they will also make people more prone to dehydration. If they get a hypolemia, they take SGLT2, they're probably more at risk of hypolemia, because these drugs not only make you get rid of glucose, they also make you get rid of sodium. That's why the sodium glucose transport inhibitor. You got that?
Sir, I have a question.
Yeah.
Sir, up to which stage of diabetic nephropathy we can use ACE inhibitor? Like which level of creatinine is maximum range? We can use ACE inhibitor.
Maximum dose, you mean, or what did you mean? Sorry, I didn't understand.
Up to which stage of CKD we can use ACE inhibitor?
Up to which stage you are saying?
Yes. Stage 4, stage 5. Up to which
5,
stage
generally we don't use it at all. Early 4 you can use it, but you just have to monitor the renal function closely along with the potassium.
Yes, sir.
The CKD patients are
when we stop ACE inhibitor, sir?
Sorry?
When we stop ACE inhibitor, which level of potassium?
Yeah. Okay. See, generally, if somebody's got a potassium at the upper limit of the range, it's stable. You can continue with the ACE inhibitor or ARB. But what I would normally do is 2 things I would do. One is advise some diet on the low potassium diet. Okay. Number 1. Second thing, just for practical purposes, really, one of the common causes of hyperkalemia in these patients is metabolic acidosis. Do you know why they develop metabolic acidosis? Anybody? This actually is another question later. I may not have it today, but something to bear in mind. Why do they are more prone to developing metabolic acidosis?
Is it because of renal tubular acidosis?
Exactly. Good. Very good. What renal tubular acidosis?
Type 4 renal tubular acidosis.
Very good. Very good. Because in type 1 and type 2, you get a low potassium. Yeah. So type 4, what's the other name for it?
Hyporeninemic hypoaldosteronism.
Very good. Yeah. Hyporeninemic. Yeah. So that is the other reason why they develop hyperkalemia. So if you got a patient who's got a borderline hyperkalemia, is very, as a nephrologist, I almost always check bicarbonate in my patients. But most general practitioners, others don't always check bicarbonate. And sometimes it's also difficult to get a reliable lab doing bicarbonate as well. So if they got a mild acidosis or even any acidosis, correcting the acidosis will also help to maintain your potassium as well. But if somebody's consistently got a potassium more than 5.5, you may have to reduce or stop the ACE or ARB. You don't have a lot of options because you don't want the patient to go on to develop a hyperkalemia-induced cardiac risk or something like that. Okay, particularly if they're going to get an acute illness, they can be very vulnerable. The second thing is also about diet. A lot of our patients don't even realize which things are, high in potassium. They will be taking some juices, they will be taking some mangoes, bananas, etc. So you may have to advise someone low potassium diet, particularly if the potassium is borderline high. So you can do that as well. Yeah. Unfortunately, some of the potassium binders are not available in India. There are some new potassium binders which are available. I have a scenario in hyperkalemia, but I may not have the time today. But I'll go through it another time. So you can use some newer potassium binders in the case of hyperkalemia. But the potassium resins, etc., you can't use them in the long term for controlling the potassium because they are notorious for causing GI side effects, etc. Okay. Yeah. Any question on that before I go to the third option?
No, sir.
The other new drug, the cardiologist here may be familiar with that, is we have newer drugs called finerenone, which is a non-steroidal mineralocorticoid receptor antagonist. In the olden days, or we still have it, spironolactone, then we have the eplerenone, etc. They're all steroidal mineralocorticoid antagonists. So they are more likely to cause hyperkalemia, more likely to cause worsening kidney function. Whereas the newer one has got a lower risk of hyperkalemia. You can never say it doesn't. It certainly can. And it's also one of the drugs we can use in the setting of proteinuria with diabetic nephropathy. So 3 drugs. So ASR and ARB, you don't combine ASR and ARB together. Okay, you should never do that. There is enough data which is available to suggest that combination drug is likely to do more harm than benefit. So it's certainly in clinical practice, we do not combine AS and ARB together. So AS and ARB we can give, then you go for SGLT2, and then you can consider a non-steroidal mineralocorticoid receptor antagonist. Okay. Any question on that? Sorry?
Gynecomastia is less with finerenone.
Yeah, it's very rare with these drugs. Yeah, that's right. Yeah. With Spiro, you can never say non-existent, but risk is very, very low with finerenone compared to other mineralocorticoid receptor antagonists like spironolactone and eplerenone. The highest with spironolactone, lower with eplerenone, very, very, very low with finerenone. Yeah. Okay.
Yes,
any question on that before I go to the question? Okay. I'll go back to the question. You can start a little bit later. So I'll do one additional question and then come to that. Yeah. So you got a man, 46-year-old man who's got increasing proteinuria. He's got type 2 diabetes. His sugar control is not great. His blood pressure is high, and he's got a he's taking beta blocker and a calcium channel blocker for high blood pressure. That's amlodipine and bisoprolol. His serum creatinine is normal. He's got a ultrasound scan shows normal size kidneys, and he's got significant proteinuria as evidenced by an albumin creatinine ratio of 210. So he's got a lot of proteinuria. You want to control the proteinuria and reduce the risk of progression of his kidney disease. So the question is, which of the following antihypertensive will be most appropriate? So you got a bentroflumethiside, which is a thiazide diuretic, got a losartan, which is an angiotensin 2 receptor blocker, methyl dopa, centrally acting agent or a vasodilator, and indapamide, which is a thiazide diuretic, just like bentroflumethiside, doxazosin, which is a alpha blocker. So which of the drugs is most appropriate?
Losartan.
Yeah, it's very easy.
Losartan.
If they give us, somebody can ask, if they give AS and ARB, it's very unlikely they will do a question like that. But as I said, unless they give a scenario, the patient's got a cough, chronic cough, or a, angioedema, usually you can choose either of the options which are available. Yeah. So ACE inhibitors are the first line. If patients got progressive or increasing proteinuria, you can consider SGLT2 inhibitors or one of the newer mineralocorticoid receptor antagonists like pinirenone or something like that. Okay. Now, this is a bit of a tricky one, which, 1 second, yeah. This I will finish before, because I said I started a little bit late. Now, the next is on SLE and kidney disease. Okay, so SLE obviously is very, very common in MRCP exams. When it comes to kidney disease, we have various ways these patients can manifest. Okay, so either they can present with relatively normal kidney function, or they can present with features of active kidney disease like proteinuria, hematuria, hypertension, and renal impairment. Third, they can just present with nephrotic syndrome. These are the three likely scenarios usually in the setting of SLE. Okay? Yeah? So now these findings tend to correlate with the biopsy findings. So when it comes to the kidney biopsy in the setting of SLE, generally we classify them into 6 stages. Okay? So I've just summarized the different findings that you might see in the different renal histopathology in the setting of SLE nephritis. Okay, so class 1 usually in the biopsy.
Please repeat the 3 presentations of SLE nephritis once again.
So when it could be somebody with SLE, but they do not have any evidence of kidney disease at all. So that means, that I mean by that is often the renal function normal, they may have very little or no proteinuria. Okay. Yeah. Second will be evidence of active glomerulonephritis, like we discussed it already in the setting of vasculitis. So they will, that means they will have hypertension, worsening kidney function, or elevated creatinine with proteinuria and hematuria. Okay.
Thank you.
The third will be a patient presenting with nephrotic syndrome with SLE.
Okay,
Yeah.
sir. Thank you.
Yeah. Okay. So usually, if the patient got a relatively normal kidney function, no proteinuria, hematuria, if for any reason anybody does a kidney biopsy, usually you are likely to have either a class 1 or a class 2 SLE nephritis. Okay. So class 1 is usually will be very mild. Class 2, there will be minimal changes in the kidney biopsy. The patient may have a minimal proteinuria and minimal hematuria. Very unlikely they're going to have a nephrotic range proteinuria or a lot of hematuria or renal insufficiency in the class 1 or class 2. Okay. In class 3 and class 4, actually class 4 is the most advanced form of glomerulonephritis. So basically here, the patient present with a lot of proteinuria, lot of hematuria, and they will often have evidence of active kidney disease as evidenced by proteinuria, hematuria, increasing creatinine, and there may be other markers of SLE which will also be very high. Will show presence of active disease. What I mean by that is they'll often have a low complements like low C3, low C4, and the DNA titers will be very high. That's double-stranded DNA titers, etc. So usually, if a patient presents with proteinuria, hematuria, worsening kidney function with evidence of active kidney disease, usually it's going to be class 4 SLE, where you get a diffuse lupus nephritis. Class 3 and class 4, it can be technically difficult to present, but generally class 4, they tend to have far more worse clinical disease than class 3. But biopsy will show various findings. So in class 3, you'll have a focal glomerulonephritis. That means what happens is only one part of the glomeruli may show evidence of mesangial expansion, hypercellularity, etc. Whereas class 4 will show diffuse glomerulonephritis. That is what is the most severe form of lupus nephritis. Often you will need aggressive immunosuppressive therapy. Okay. So class 5 usually will present with nephrotic syndrome. So it can be just like any other nephrotic syndrome. So you can have a typical patient with minimal change membranous, FSGS, etc., present nephrotic syndrome. But if the evidence of SLE, you have to think of class 5, which is usually causes what we call is a membranous nephropathy. Okay. Usually the renal function will be normal, though they can have a high creatinine. So typically speaking, class 5 SLE with membranous nephropathy, they will present with nephrotic syndrome. Usually renal function is normal. But what happens when you do a biopsy, in addition to membranous nephropathy, when you do immunofluorescence, you will get, what will you get in immunofluorescence? Anybody?
Full house.
That's right. Good. You'll have a full house immunostaining. If somebody's got a nephrotic syndrome and have SLE or a full house immunostaining, you have to think of class 5 SLE nephritis. Okay. So full house, you mean there will be presence of IgA, IgG, C1q, C3c, etc. So that's what we mean by full house immunostaining. That is a hallmark of SLE nephritis. Okay. Whereas the last one, where what we call is an advanced kidney disease. So usually these patients have a progressive kidney disease or may have a severe renal impairment. Urine may or may not show a lot of proteinuria, hematuria, but the biopsy is so advanced glomerulosclerosis, and it can be very difficult to distinguish from any other advanced kidneys apart from the finding on the immunofluorescence. So usually your immunosuppression, etc., is unlikely to be beneficial in a patient with class 6 lupus nephritis. So usually you will consider immunosuppression in class 3, 4, and class 5 nephritis. Okay. You got that? Any question on this one?
Sir, immunosuppression will be considered in
3 and 4 and also in 5. Usually, if it's class 4, you have to treat them with aggressive immunosuppression, like steroid plus MMF plus or minus, either MMF or cyclophosphamide, depending on the clinical situation. Yeah, class 5, you can go for a steroid plus MMF, or you can also use calcineurin inhibitors as well, or rituximab can also be used. So, but class 4 is the one with the worst prognosis. I mean, class 6 is also there, but the kidneys are already damaged. You're not going to reverse that. But class 4, if you treat it, usually can improve or recover the renal function. That is important to treat class 3 and class 4 aggressively. Okay. Yeah, you got that?
Yeah.
Okay. Now I'll go through the question. Yeah. Okay. So 31-year-old lady, Asian woman. So these SLE is relatively common in Asian and people of Afro-Caribbean origin. That's why they may give a scenario like that. Who presents to the rheumatology clinic with increasing edema for about 2 months. She is known to have SLE, for which she is taking steroids plus hydroxychloroquine. And you examine the patient, you find that the patient has got slightly low blood pressure or normal blood pressure. She's got bilateral leg edema. She's got normal serum creatinine. Her albumin is low, and she's got a very high proteinuria. So here, the patient had evidence of nephrotic syndrome. Yeah, got proteinuria, nephrotic range proteinuria, edema, hypoalbuminemia. They have not given the data on the lipids, but they got features of nephrotic syndrome. You got that? So if you got a nephritic illness, you will think of class 3 or 4. But because he's got a nephrotic syndrome, it's likely to be
class 5.
Yeah, that's right. A membranous nephropathy. Okay. So interstitial nephritis, we already discussed it. Usually, you don't get nephrotic syndrome in interstitial nephritis. It's usually you have only minimal changes on the renal function. You do not usually get a lot of proteinuria or edema, etc. Membranous nephropathy is a likely diagnosis. Minimal change, it can be, it can't rule it out. But given that the patient's got SLE, it's likely to be membranous nephropathy. Yeah. So
Okay,
Likewise, diffuse proliferative glomerulonephritis, like a class 4 SLE, it's not impossible, but the patient is typically as presented with a nephrotic syndrome, which makes it more likely to be a membranous nephropathy rather than proliferative glomerulonephritis. So if it's proliferative glomerulonephritis, you would have got increasing creatinine, you would have got active urine with more hematuria, and there will be they might have given other markers of SLE also showing evidence of active glomerulonephritis. Okay, and FSG is just another cause of nephrotic syndrome. Again, given the history of SLE, it's most likely to be what is that SLE causing membranous nephropathy. Yeah.
Yes.
Okay, and I'll stop with that. You got any questions till now, or any of the questions that we discussed today?
So one doubt regarding the class 4 and 5.
Yeah.
So in both of this, the nephrotic syndrome will be seen in, or
no. In class 4, you will get a nephrotic range proteinuria, but you don't usually present with nephrotic syndrome as such. See, basically nephrotic syndrome, what we mean by that is patient of edema, hypervinia, nephrotic range proteinuria. But in typical nephrotic syndrome alone, they're usually not hypertensive. They generally do not have elevated creatinine. Whereas in the nephrotic illness like class 4, what you see that the patient will be hypertensive, they will have proteinuria and hematuria, and the renal function will also be quite abnormal. That's what we mean by that. You got that?
so in class 5, we won't be getting hypertension.
Very unlikely. You can get it. I'm not saying it's impossible, but typically they will just present with nephrotic syndrome.
Sir, in class 5, will we get dsDNA and C3?
Yeah, it can be because they got a what is that SLE, no. So DSA is likely to be positive. Though, as I said, in clinical practice, you will see all these things. But with regards to exam perspective, generally, if patient got a nephritic illness, it's likely to be a proliferative glomerulonephritis. Whereas they got a nephrotic illness, think of membranous nephropathy. Don't pay too much attention to ANA, double-strand DNA, etc. Because in a patient with SLE, if they got an active disease, they are going to be likely to be positive only.
Sir, one thing, what is the renal biopsy finding of membranous nephropathy?
So usually you will just get that. What you get is that there will be that pinhole lesions will be there. There will be thickening of glomerular basement membrane. Whereas in diffuse proliferative glomerulonephritis, you find that there will be increased mesangial expansion, there will be hypercellularity, etc.
Capillary wall.
Yeah, that's right. Yeah, capillary wall thickening, etc. will be there. But membranous, you won't see much proliferation, like increased hypercellularity, mesangial expansion, etc. won't be there in membranous nephropathy. You'll only see thickening of the glomerular base membrane typically. Sometimes they'll get these pinhole lesions. Yeah. Next time I'll try and get a picture that I can show it is here. Here. Yeah. Sorry. Yeah.
Sir, excuse me.
Sorry.
Sir, every heart they.
Sorry, I couldn't hear you. Tell me.
Proteinuria is there.
Yeah.
Nephropathy and hepatitis. But the range of proteinuria, can you tell the range of proteinuria in different classes? No, how much proteinuria you will get in different?
So generally in nephrotic syndrome, the proteinuria will be more than 4 grams per day, generally.
Okay.
Okay. But typically...
And membranous nephropathy?
Typically it will be more than 4 grams.
Okay.
Yeah, because membranous nephropathy will typically present with the nephrotic syndrome. Whereas the other class 4 will present with a nephritic illness. So generally in nephrotic syndrome, what you'll have is generally the blood pressure will be normal. Okay. The creatinine will usually is normal, not always. But the patient will have a lot of edema, lot of proteinuria, albumin will be low, and they will have hypercholesterolemia as well. That information is given. But in nephritic illness, what often happens is that you will have hypertension, you have elevated serum creatinine, you have proteinuria and hematuria. Yeah, that's how we distinguish it clinically. Yeah. But as I said, in clinical practice, it can be 1 second. I'm just going to find that clinical paper for you, and I'll post it in one of the slides. Just 1 second. Then you can get the link. Just 1 second. So you can, this is the link for that preview paper. You can note it down. Yeah.
Thank you, sir. Thank you, sir.
You can just note it down. I think that's the right one. 1 second, let me just, because I have the link there. Yeah, that is the one. Yeah, it's from the
General breathe.
Okay. Yeah, breathe. Yeah, that's right. That is the link. I think if you take a note of the link, you type it or copy it. I don't know whether it allows you to copy, or you can take a photo and then type it in, etc. or you just put that author's name, etc. I'll show it again. It should come up.
It's seen in ERS. No, I have it. No issues.
Yeah, you can use this. If you take a note of this author and the title, put it in Google, I'm sure you will get it.
Yes, sir. ERS is European Respiratory Society.
Yeah, that's right. But this is a different journal, I think. I thought it was European, but it shows something else. It says sleep.
No, it's breath. Breath is.
Breath, yeah, that's right. Yeah. I thought it's not it's a breathe. That is the journal name. Yeah. Yeah. I'll just show you the link. I said you can make a note of that. Yeah. I think it's must be a European Respiratory Society journal, I think. Yeah. Obviously, I'm not a pulmonologist, so I don't know exact journal, but anyway, that is what I got it from. Okay. Yeah. Any other questions?
No, sir.
Okay. All right. Okay.
Thank you
Good
very
night,
much, sir. Thank
everybody.
you.
Thank you.
Good night, sir.
Okay.